Uh, awesome. So I don't know who all's there, but I'm kind of curious, like how many med students and kind of who the audience is.
Yeah, I think it's mostly med students, obviously Dr. Fullerton, um, and then I think and then we have Dr. Nutting as well, who's a resident in College Station.
Awesome. What kind of resident?
Family medicine. I'm applying to sports medicine fellowship right now.
Awesome. I am
Hmm.
too.
Oh, really?
Yeah.
Cool.
Yeah, for sure. Hope it's going well.
Yeah.
Uh,
Cool.
so I want this to be definitely a very informal thing and chime in whenever. Hopefully we can learn a little bit as we go through this. Um, Nothing disclosed, not really talking about any sort of meds or devices or anything. And again, Andrew, are we trying to knock this out before 8 Texas time?
I if you want to go a little bit longer, that's fine with me too. People can always leave if they have places to go or some sleep to get, and we're recording it, so we'll post it on our YouTube after the fact, so people can watch the rest.
Okay, cool. I just want to make space for questions as people are still around. So this is a photo or I guess like a little time lapse video of Everest Base Camp looking up at the ice fall, and then can you see my mouse too? Does that share?
Yep.
Yeah. Okay. Cool. So that's actually Lhotse, and then Everest is up there, and then Nuptse is this massive over here. Yeah. So like I said, hopefully you can learn a few things. So yeah, I grew up in Dallas, did family medicine residency in Dallas, and then first job out of residency was in Jackson Hole, where I did kind of inpatient, outpatient medicine, kind of longitudinal excitement or history or passion has always been mountaineering and playing outside in whatever capacity. And as I just said, I'm actually in the process of the sports medicine application and kind of have circled back after having a beautiful career doing lots of wild wilderness medicine things so far. Currently I work as a hospitalist, which gives me a lot of the flexibility that's needed to do a lot of these expedition things. This winter I'm going to do ski patrol at Big Sky, kind of in and amongst everything else I'm doing. I teach a lot of wilderness medicine courses, and that in the last kind of 18 months is taken me all over the world. And actually that's how I know Heather is helping teach one of the wilderness life support courses down in just north of Austin. So this another cool shot of just to give you like layout of Everest Base Camp. So this is basically the bottom right of the photo is kind of around maybe 17,200-ish. And then where the camps or like the yellow tents sort of peter out on the left is closer to 18,000 feet, and it's probably spread out over maybe a mile or so. And then this is the famous ice fall that the Sherpas, there's like a dedicated team of Sherpas that they secure the safety and like the route through there through the climbing season. And then you can just see the Everest little summit up there in the clouds. And yeah, so the structure of this is try to talk a little bit about high altitude illness, and then get into some clinical cases, and then I don't know, have interspersed interesting stories. And so just in terms of incidents of like why medicine and science cares about altitude illness, these are just numbers that are out there from recreation standpoint. I imagine some of you guys have gone to Colorado, Utah, New Mexico, Montana, wherever to go ski in. And basically we start physiologically carrying about altitude illness once we get above 8,000 feet or like the 2,500 meters. And then the like in the Himalayas, like the Everest, typical like trekker plus climber cohort, right before COVID, it was like right above 20,000 people that were just solely going in the Everest base camp track drainage. And that's not even the Annapurna circuit or, some famous treks that are in like the India Himalayas as well. Gosai Kunda is a pretty interesting thing. It's a religious pilgrimage that gets up pretty high as well. A bunch of folks each year do that. And then, for specific peaks, Rainier or Denali, the numbers trickle down. So in terms of, I don't know, just trying to look at this a little bit differently, who gets acute mountain sickness, which is basically, and I'll define that a little better here in a minute, at each of these places. So almost a quarter of the folks that are going to Colorado ski resorts will do that. And, just for example, like the town of Breckenridge is at 9,000 feet. So you're definitely up there. And then a lot of the folks that end up climbing Mount Rainier, they do like a 3-day itinerary, and a lot of them are coming from sea level or close, and then fly to Seattle, which is at sea level, and then, over a 2.5-day trek window, getting up above 14,000 feet. So here's another attempt to try to consolidate some of these numbers, just to say that like acute mountain sickness is a problem and does happen. Rate of ascent is one of these columns in this graph, and that definitely plays a role in your body's ability to deal with the hypoxia stress. So just kind of quickly, and I won't get into the weeds with this at all. And actually, I think I said even more concisely. Here we go. So in the first couple of days, your body diureses basically hemoconcentrate and sort of acutely give your body more processing power to carry that oxygen. And then, also immediately your body's spitting out erythropoietin to make new red blood cells, but that doesn't accumulate to any like legitimate appreciable red cell mass to carry more oxygen for kind of that 7, 10, 14-day time frame. And then in terms of sort of like recommendations, once you get to that 8,000 foot, 9,000 foot marker, this comes from the clinical practice guidelines for acute mountain sickness or altitude illness. And these are from the Wilderness Medical Society. And this is a cool resource for just like anybody interested in wilderness medicine, period. These are free PDF downloadable clinical practice guidelines that are updated every couple of years. And they actually just sort of pre-published the new altitude update recommendations. So in anything more than the like 9,000 foot window, you need to start thinking about the rate of ascent in terms of minimizing your risk for acute mountain sickness. So each sort of like new elevation, they recommend 1, 2, 3 nights of acclimatization time frame. And it's kind of like taking this logic and dumping it to the typical trek, going up from Kathmandu to Lukla and then up to Everest Base Camp. And actually I have a better sort of like map/graph of this to lay out the elevations, but kind of recommend doing this at each new elevation. So like if you're at Everest Base Camp for more than a handful of days or a week, likely you're going to be pretty acclimatized to that elevation. But as soon as you re-stress your body going up to Camp 1 or Camp 2, and then sort of as the acclimatization of the the summit climb goes on, they recommend having these breaks at each sort of new elevation change, as long as it's kind of that 1,000-foot increment is what they say is going to be like low risk of acute mountain sickness. And then 3,000 feet, if that's the gain, then you're going to be at higher risk of acute mountain sickness. So kind of the different diagnoses that are related to high altitude illness. So headache, I mean, it's just purely that, and probably multifactorial in terms of dehydration. And then acute mountain sickness, so I'll talk about that here in a minute. And then pulmonary edema and cerebral edema, the flatus expulsion, talk about that as well. And then chronic mountain sickness, which is, and then the reentrant pulmonary edema. Those things I won't really talk about, but pretty interesting just in terms of literature and case studies. So acute mountain sickness, I'm gonna use this. So Lake Louise, this is how we try to objectively score it. The one on the right is the newer one. The one on the left is the older one. And basically it has these questions in regards to, do you have a headache or not? And you can't, by definition, or like what's clinically accepted, have acute mountain sickness without a headache. So you need a headache, and then kind of how bad is it? 0, 1, 2, 3, and then GI symptoms, fatigue, dizziness, lightheadedness. And then what they added in this most recent score is this like clinical function score of like, how bad does it affect what you're trying to do? So then in terms of sort of what we look at, again, it's like you're at risk when you do rapid ascent over that, 8,000-9,000 foot mark. And then symptoms, like I just went over. So you need the headache, and then that constellation of symptoms, and then kind of what we think is going on in terms of pathophysiology is you have vasodilation. And I'll say this in regards to this conversation, acute mountain sickness and high altitude cerebral edema are on this spectrum. Whereas high altitude pulmonary edema is like a technically sort of like different pathophysiology. So with acute mountain sickness, the cerebral vasodilation, increased blood flow, increased intracranial pressure, and then some of that with different chemo and baroreceptors, it leads to hypoventilation, impaired gas exchange, and those are, what we think give the symptoms that you have. So this again is from the Wilderness Medical Society's clinical practice guidelines, and sort of the research using, I think they use the CHEST kind of algorithm to come up with these recommendations. But gradual ascent, acetazolamide or Diamox is both prophylaxis for use for prophylaxis and for treatment. The 125 milligram is, I don't know, newer, and basically the old recommendation was 250 for adults twice a day, and then have been shown kind of in non-inferiority studies that 125 is clinically as efficacious, and you have less side effects. And then the dexamethasone, unfortunately, there's probably some people doing high altitude running races, like there's several in like the Leadville 100-mile race, that kind of thing, or cycling races, in the Alps or also in the US, or people. I mean, there's a really interesting case study about a climber that was climbing Everest, and this was I don't know, maybe early 2000s, 2005, 6, somewhere in there. But basically his primary care doc recommended that he take dexamethasone, daily. And what ended up happening on his summit rotation, once he got up to Camp 3, he ran out of meds and then had acute adrenal crisis, and luckily lived through the ordeal, but was in the ICU and back in Kathmandu for a little while. So pretty interesting thing, and definitely something to think about, one, in terms of having conversations with prospective patients in regards to like educating them on different things they can do when they're going to family vacation and at Machu Picchu or climbing Kilimanjaro or kind of anything that's taking them above 9,000 feet. And then ibuprofen has also been shown to be efficacious for prophylaxis. It's kind of interesting in my mind, and something that I don't really recommend. You also have a pretty interesting thing at high altitude where your like tight junctions in your GI tract loosen, and you kind of have like microscopic bleeding, and then just throw ibuprofen on top of that. I feel like you're setting yourself up for an ulcer. Similar discussion, like I've run into guides up on Everest that are taking aspirin every day, and just the discussion of, or I'll say this, the reason why they were doing that is to help with like platelet coagulation related to frostbite, but then also one of the other reasons was basically like this thought that they would be at increased risk of a blood clot at altitude, which isn't wrong. I just think that kind of the risk benefit does not weigh on the side of taking aspirin up high. And then this other stuff has basically been shown to not be helpful. Hypoxic tents is helpful for prophylaxis in terms of like pre-acclimatization. And actually, I did that before I went to Everest this past spring. And then iron, it's important that your iron levels are up just so you can, once your body starts kicking out the EPO to generate more red blood cells, that you can have enough iron to do that. And then on the right, staying hydrated, getting good sleep, and minimizing alcohol are definitely important things. So pulmonary edema. So again, kind of similar risk, just fast rate of ascent. And then kind of in terms of the pathophysiology develops over a couple of days. So in terms of diagnosing it, you're going to have a patient that's going to just be short of breath at rest. And again, it's kind of all relative, especially the higher up you go. When you're at 27,000 feet, everybody's short of breath at rest. So it's kind of like, what does that look like compared to what they were, the day prior, and or compared to like the buddies in their same climbing group that have had the same itinerary. On exam, have some junky lung sounds, vaguely, and then like the stereotypical thing is pink frothy sputum, just because they're like bleeding into that interstitial space and then coughing up from the alveolar hemorrhages. And then treatment is descending oxygen, and then the nifedipine calcium channel blocker basically vasodilates the kind of targets multiple things, but one of the things it targets is the lung vasculature. And then sildenafil or tadalafil has also been shown to have some benefit clinically for the same reason of decreasing the pulmonary artery pressures. People that are going to be predisposed, all this is a little bit common sense, I think, but somebody that has increased blood flow, pulmonary hypertension, heart failure, that kind of thing. Cerebral edema. So again, it takes a couple days for this to really like manifest itself. Symptoms and the way people are going to manifest is like any sort of neurologic changes at altitude. So you're going to have this is a spectrum of acute mountain sickness all the way to high altitude cerebral edema, which, unfortunately culminates in death for some folks. I have a little bit of a case study a little bit later, but basically treatment, again, descending oxygen, and then dexamethasone is the drug of choice for this. This dude, I don't know if y'all have heard the name Paul Auerbach. So he's one of the godfathers of wilderness medicine. If y'all have seen, it's now like a 2, if not 3 volume textbook, the wilderness medicine, but he's been the editor of that for a while, but he passed away recently. But he wrote this excellent paper in 76 on high altitude flatus expulsion. So it's important in your didactics to understand that this is another important thing, that pressure changes, you end up being more gassy at altitude. All right, so chronic mountain sickness, I don't actually understand a whole lot about it, but you basically have sort of like deficits as a result of the polycythemia, end up having heart and lung issues long term. And some of this like potentially have seen in some of the Sherpas or some of the folks that are living at 14,000 feet year round, and going higher periodically. And I think some of this, like these populations in the Andes or the Himalaya, like self-diagnose and end up moving lower elevations to have better outcomes. This is just a table to try to make concise prevention and treatment doses of the different drugs. And then I think this is a video. No. So this is Everest, this big black rock massive. That's the summit up there where you can see the wind blowing. This is Camp 4, or the South Col. And then Camp 3 is kind of like in this zone here. This whole thing is the Lhotse face. And you can kind of see where this isn't climber like a row of climbers, but this is like all the footsteps in the ice leading through here, the yellow band up through here. And then there's a little camp here, just out of the way of this couloir here. So this is the like the route of choice to climb Lhotse, which is this mountain here. And then if you're going on to the South Pole, you'll go over the Geneva Spur here and then end up at Camp 4 and then the summit push. Now people are leaving, you know, kind of like 9-10 p.m. From here, summiting and then getting back down, maybe rest a little bit, and then try to get all the way back down to not only Camp 3, but even back to Camp 2 as best case scenario. So these are different languages of folks that I had just on my team last year. Throw Australian and Kiwi in the mix because sometimes they're difficult to understand. So once May 1 hits, and the kind of schedule is basically like most people get to Kathmandu around early April, and get up to base camp sometime around like May 10 to 12, 14, somewhere in that window, and then rest a little bit and start having their acclimatization rotations. And the first of which tries to climb a mountain that's like 21,000 feet back down the valley. But once May 1 hits, we start getting daily weather updates from actually a couple different sources. So this is just kind of an example of what I get in my email, you know, daily in May. And we do have email up there. We have pretty good Wi-Fi. I mean, I actually have done similar chats over FaceTime to people from up there. So food prep, you know, interesting thing. There's not refrigeration up there. And, you know, once you get into May, everything thaws out during the day and refreezes at night. We use it's kind of sad, but we use the glacier as a refrigerator. And I end up going vegetarian once I get up to base camp and we get into May. I just don't trust what's up there. In terms of water supply, I mean, it's unlimited. I mean, this is the you know, the heart of so many just massive rivers downstream. In terms of purifying or getting rid of, you know, viruses and bacteria and the like, this is just a good graph, I think, to realize what the boiling temperature is, and then also important to sort of like understand that 160 still kills basically all the viruses and oocytes and oocysts and the like that, you know, we would worry about up there. And then, can you see this little video?
Beautiful glacial river.
Yeah. This is
Everest base
at base camp.
camp.
And then that's an outhouse, you know, just at base camp. So everybody poops into these like 50-gallon buckets up there. And it's just, you know, like comical that a lot of people are, you know, drinking out of these same streams. So this is just, I don't know, a graph that I found to try to depict some of this stuff. So boiling is a great thing as long as, you know, your boiling temperature is going to be over the temp that's going to actually kill these things. And, you know, at base camp, it is. So again, at base camp, this is, a lot of teams have gone to these little like white geodesic domes, just giving clients more space. And then these things, and then there's like smaller, you know, mountaineering tents that are still prevalent all over base camp and then also higher on the mountain. And then this is one of the team's solar panels, which is just wild. But that team actually also has some of these geodesic domes that have like heated blankets and humidifiers in them, and all that's run on either generators that are diesel or off of the solar. So kind of the beginning of the season, there's going to be some auspicious day that we decide to have a puja, which is basically like the blessing ceremony, and then asking the god of the mountain to, you know, sort of like bless the travel and the safety. So that's a pretty cool day. It's normally more of like a party. You know, some of the teams are definitely partying into the wee hours of the night on the night that they choose to do the puja. So like you can see in the photo, I threw my stethoscope up there to get blessed. So then this is typical itinerary. You'll kind of fly to Lukla, and then spend the night at Facting. So this is going to be like 9-something, 10-ish thousand. Namche Bazaar is a little over 12. Then Tengboche, Feriche is at 14. Dengboche is like 14 something thousand. Lobuche is 16-ish something. Gorik Shep is like 16.5. And then EBC is like 17.2. And then this is like a typical trekker's itinerary where basically they go up to base camp and then they climb this mountain called Kalapatar, which has a beautiful little viewing platform to actually see Mount Everest, and then basically hightail it all the way back down to Lukla and fly out. And then that whole thing will basically be maybe like an 8 to 10 day itinerary. So then this just like lists that out a little bit differently. So hypoxic tents, actually last year, so I actually like had this little setup. There's a couple companies that make these things. And there is like plenty of anecdotal evidence. And, I ran into plenty of climbers up on Everest this year that were both training in hypoxic environments. So like a bigger room that's basically hypoxic, and, the companies that are doing these things can change the elevation from 9,000 up to like 22,000 feet as you can in these little tents. And it's pretty interesting. It's basically like unzip it, jump in, and then all of a sudden you're, whatever elevation you are at any given time. So I kind of started 12,000 and got up to 15,000 feet over a couple of weeks of just trying to sleep in that. The literature, I feel like it could be better, but basically, you need to sleep in these things for several hundred hours to have it have clinical benefit. Sorry, I'm just seeing this little chat. Oh.
I gotta run. I'll be back in a little bit.
Yeah. Sorry about that. So then altitude masks. So these things are shown not to help. And basically they have some sort of like airflow restriction to them. And then this is another thing, potentially you've heard of these, gamma bag or a portable altitude chamber. So it's literally like the size of a human, it's like 6 feet long and maybe like 2 foot diameter. And basically you just pressurize these things with a little foot pump, and you can throw a patient in there that has, pulmonary edema or cerebral edema with an oxygen tank. But this is a photo that I took when I climbed in Bolivia in '99, and just like my buddy inside the tent, he thinks in terms of the pressure in there, he's at 10,000 feet, whereas we were in the Little Refugio at 15.6. So that's a cool, easy, quick treatment, but you have to continuously pump on these things so that it's laborious. And then also, it's not insulated, it's not nice, it's very slippery. So like the practicality of having these things anywhere, especially like on Everest, anywhere higher on the mountain, is not great. And then sort of like having that discussion of, what benefit is this going to have versus trying to get a Sherpa to drag somebody down or get a helicopter, to grab somebody. So this is like typical amount of stuff that I'll travel with over to Everest. Like 1.5 of those bags will be like my personal mountaineering kind of stuff. And then 1.5 of those bags will be medical stuff that I bring from the US. And I'll have more photos of like more medical kit stuff here in a second. But an easy way or a good way, sort of acronym to try to think about what you want in a med kit, is just this little acronym PAUSE: so prevention, procedures, and then A, analgesic, antibiotics, antiseptic, anaphylaxis, then wound care, and then survival stuff. And like the survival and weather kind of stuff, I feel like is more just like personal belonging, especially like thinking about a mountaineering trip. You need a lot of gear with you. So important to try to, if you're going to be the medical director or the doctor for an expedition, really understand what the past medical history, vaccine status, dental status of all the clients, guides, porters, like everybody that's going to be, under your purview. And I have kind of based on whatever trip I'm going on, I have different documents that sort of try to get, all this thoroughly teased out, so that I can like pack better and have a better understanding about what I may see and treat wherever I am. So then other things to think about, like, one of the common discussions is like controlled substances. I mean, there's some countries you can't even like transit through with those. Some you can, but you need very specific documentation that's like laid out on their different government websites that they have. And then so kind of like this is a mix of different medical lists for Everest, but basically start with a Word document of all the things that I need, and then when I get over to Kathmandu, like run through all the stuff from the last expedition. And the team that I go with over in Nepal, they do multiple other 8,000 meter peak expeditions throughout the year. They don't have a doctor with them except for Everest, but they'll use a lot of the same medical equipment. So I'll thoroughly go through all that and figure out what else we need and what I need to like run around Kathmandu to grab more of. So this is just kind of an example of some of that. And then like we don't see this a whole lot anymore in the US, but like these glass ampules for a lot of the different meds. So some of the like wilderness medicine, expedition medicine, third world country medicine is like going back to some basics of like, how do you reconstitute meds that, like we potentially don't get in some of our training unless you're, really trying to interact with pharmacists or, nurses to like learn some of these skills, or like, how do you start an IV? Where can you do venipuncture and all that kind of stuff. So all of those things definitely come into play. And then these are like smaller little kits that I'll send up with kind of as this season progresses and more clients or Sherpas are higher on the mountain, I'll have like a decent kit at Camp 2, Camp 3, Camp 4, and then things that are going to be more perishable or I can't have freeze, we'll just keep with a specific Sherpa. And then I give each of the clients their own little pill container that has kind of the 3 crucial drugs of treatment for the acute mountain sickness, pulmonary edema, and cerebral edema, and that's the Diamox, or acetazolamide, dexamethasone, and nifedipine. And then I have the Sherpas carry some like intramuscular versions of that stuff too, which is what these are. And then like you can see what's written on here. So like ketorolac and epinephrine, and then the things where it says like 4 and 8, that's dexamethasone. And then I thought this was kind of cool. One of the Polish climbers last year, he had this that was given to him by one of his doctors. And it's basically like a bunch of different antibiotics, pain meds, GI meds, altitude meds, that kind of thing. That was all like labeled out pretty well, which I thought was pretty cool. So just in terms of trying to get through some of this and leave some time for questions. So one, like I was up there in 2021 with COVID, and my team actually flew 2 nurses up from Kathmandu to do PCR swabs. And then like 9 of the 67 people on my team were actually positive. There were 6 of those people that actually before, it was only a couple hour window between when they came up to administer those tests, and then by the time they were back down in Kathmandu and actually get all the results. But some of those team members actually went up to Summit because that was their kind of like weather window. And even though they were positive, they neglected to come back down. And it just kind of like this other discussion of, especially a place like Everest, a lot of people have a lot of time, energy, and money dedicated to this whole pursuit. And sometimes people don't do what is in the medical best interests of themselves as a patient or to everybody else on the mountain. So that was pretty frustrating. And then we ended up putting one of these nurses up on oxygen, so they basically flew from 3,000 feet to 17.5, and we're only there a couple hours, but your body just doesn't want to tolerate that. So this was something I learned in the first year that I was there. The regulators that are on the oxygen bottles, I don't know if you can really see it in this photo here, but basically it's kind of all proprietary stuff. So like they don't work with nasal cannulas like we have in the hospital, or like I brought over and bring with me to treat people, or the same thing with like the atomizers or nebulizers, like those don't fit on those regulators. So that was just something that I learned by doing and learned by trial and error. So each time I've been back, I'll bring these like double Christmas trees that'll slide into the proprietary tubing and then slide into the normal tubing that we have in the hospitals. So this was an interesting, unfortunate case. There was an eight-year-old girl that this was like on a day trip going from Everest Base Camp back down to Lobuche, which is like 16,000 feet. And this girl was just in like the little coffee shop there with her mom. And literally, I mean, just like I have not ever, I think in my whole medical career, seen somebody so cyanotic. And her O2 sat with a little pulse ox on her finger was in the 50s. And her mother, so she was Russian. Apparently the dad was Sherpa, and they had spent a lot of time in Nepal, but this girl had never been at this altitude before. And it was just kind of a lot of the like expedition medicine things just like crashing into one little case of like language barrier, cultural barrier. She said she was a doctor, it turns out she's a vet. And then some other like discussion of like COVID's not real, but what ended up playing out with this girl, there was another just client from another team, and he paid a Sherpa to throw this 8-year-old girl in basically like a big basket and on oxygen and run down the mountain, because unfortunately all this played out at like 6 p.m. as it was getting dark. Lots of ophthalmologic things going on up there, so it's not uncommon. You're just on a glacier for basically a 6-week time frame, and you really need to have sunglasses on all the time, otherwise you're going to basically get sunburn or UV keratitis, and that unfortunately the higher up you go, the worse off that can be in terms of complications of you have difficulty seeing, and then all of a sudden difficulty traveling down, getting down, that kind of thing. So a scary deal. So these are, just kind of 2 antibiotics that able to procure over there, but another mainstay of treatment for this, tetracaine, so just to numb the eye, and then a couple different NSAIDs that they have in drop form over there, ketorolac or otherwise, definitely help with the inflammation and the pain of what's going on. And I think that brings up like a good thing to say in this regard of like expedition mountain medicine. I think it's some of this discussion with like sports medicine of like you treat the high school player differently than you treat the person that's literally in the Super Bowl. Like these people are at the Super Bowl of mountaineering. They spent so much time and money to be here that you like practice outside of some of the judgment you would have if you were in a town, to help them, one, succeed at their goal, but also do that safely. So it's a really interesting conversation. So this dude was on my team in 21, and he was blind. He's the second blind guy to climb Everest. He did succeed, but like in that effort, he took 4 Sherpas up with him. One of the Sherpas on his way down got solar keratitis, basically because he had to give his goggles up to somebody else. And then this discussion of his regulator broke on his oxygen tank, and just this like trickle down effect of him being like much more slow, and just some of that like hubris greed conversation of like, why does this guy need to climb and summit and put other people's lives at risk? kind of conversation, which I mean, there's just like a plethora of those conversations that happen up there. Contact lenses are awful. This is me before LASIK. Unfortunately, so LASIK actually is awesome up there. There's an older version that potentially is not great once you're, kind of like 26, 27,000 feet and higher. But back in glasses and contacts, back doing this rigmarole up there, and it's just an unnerving thing to have dirty hands, dirty fingers, predispose or increase your risk of getting some sort of corneal abrasion or whatever bacterial infection. So psych stuff definitely happens up there. Had a good case 2 years ago of a client that actually had already summited Everest, and then she was coming back a different year to climb Lhotse, had a known history of anxiety, climbing up the Lhotse face. So if you remember in that little picture towards the beginning where I was saying that the route goes up this couloir to the Lhotse face opposed to up towards Camp 4. So she was in that couloir when some Sherpas were bringing down a body from a deceased climber from the season before. And she just had a full-on panic attack up there. And, kind of, there's no right answer to this, but, interesting conversation of like, do you give benzodiazepines up that high? My, Gestalt says no, because these people still have to do technical mountaineering, descending, use rappel devices, that kind of thing, and anything that's going to change their breathing, contribute to respiratory depression, or change any sort of like mental clarity, cognition, I'm not happy to do or willing to do. So a lot of reorientation with this climber. Neurologic stuff. So let's see if I can play this video. So if you can tell, this guy's actually using trekking poles, but still really ataxic. So he's at base camp, so like 17.5. And this actually was this guy's baseline at sea level. So, again, just an interesting conversation of, differential diagnosis, and also like knowing people's history. I was not comfortable with him walking around like that, like as we're literally living on a glacier for a while. So this guy slip and fall at any given time. But also like pretty interesting. That guy was a really accomplished mountaineer. So it was fun to have him up there for other stories. And he was that year that I took this, he was our sort of like base camp manager. So also dealt with some concussions up there, and kind of like the thought would be you don't want to have a concussion up at high altitude, an acute one or one that you're dealing with. So just kind of different things that you might use in the city, in the clinic, in the hospital, or on the sideline, to evaluate those kinds of things. Not a lot of literature in regards to concussions at altitude, though. So this was another pretty interesting case. This guy basically had left-sided arm and leg weakness and pain. He had already been up to Camp 4, and he was on like a separate rotation. And then basically the long and short of it, lots of things on the differential, pulmonary edema. He actually was diagnosed. He had some respiratory stuff too, but the high altitude cerebral edema versus a stroke were like the two highest things on my differential. And it was just conversation of like getting this guy off the mountain, treating for cerebral edema, because that's what I can do there, and just hopefully get a helicopter as soon as we can. And this is MRI of his brain, which was basically normal by the time he got back down. Showed sinusitis. So if you're able to like capture imaging on these people, in a more acute phase, you can see abnormal imaging. And then this is just rest of his labs. Kind of interesting. See his hemoglobin was 15.2. In my mind, I would think a Sherpa that's living up there and spending so much time up at altitude would be a little higher than that. And then dentistry. So I played dentist up there, and actually, like occasionally when I'm at the dentist, I'll ask a bunch of random questions of my dentist, and have them show me different techniques and that kind of stuff. And then at different like wilderness medicine conferences, I've taken some little courses on dentistry, but I've pulled teeth up there. I've packed teeth, built like a little retainer for basically an avulsed tooth with a paper clip and super glue. Lots of downtime up there. Dermatology, pretty interesting stuff. So this actually was just a contact dermatitis from a muscle cream. This, I still don't know what this is. I've sent this around to multiple dermatology buddies since I took this photo 2 years ago. This is just unfortunate case of new boots. And another, it brings up another good point of altitude. Your body doesn't heal. So these actually are taken, these photos are taken a month apart, just kind of like simple abrasion, which, you know, back here should, you know, heal up and look like the photo on the right within a week or so. You know, just doesn't heal. This is sunburn. It's actually my neck on the left. Climbing on a glacier on Mount Rainier. I forgot to put sunblock like in between my shirt and my buff, and I just got blasted. And then similar thing, a buddy on the right, when we were skinning up Mount Rainier, it was a gorgeous day. He was in shorts and just forgot to put sunblock on the back of his legs. So frostbite, this is just like a progression over a couple weeks. On the left was kind of the immediate thing, maybe 3 days after he had the exposure. And then the far right one is kind of like a month-ish later. So some more frostbite. The kind of management of frostbite up high is, you know, if you can warm it and thaw it and not have the possibility of refreezing, then you want to do that. But if there's any sort of thought of refreezing, then you just want to keep it cold, because doing that freeze thaw process just damages tissue more than not. So this climber had already come down, and I was just debriding and just doing wound care. This guy, unfortunately, is one of these things. He's a Sherpa. He wanted to go back up and help with some of the taking down of tents and whatnot at the end of the season. And it's one of those, you know, conversations of you only have one pair of toes, and you know, pro con discussion. And all I can do is like give my medical advice and let the owner of the company and individual clients or Sherpas, you know, make a decision. So GI stuff, lots of GI illness, especially on the trek in, as everybody's, you know, kind of new in country, just getting exposure to different bugs, not even bad bugs, but just different gut flora. So this actually was pretty funny. I had a Sherpa come up to me with this discussion of basically hemorrhoids, and, you know, kind of did an exam to evaluate that. They were, you know, gave him some hydrocortisone cream for it, talked about some diet changes, and then like over the next couple of days had several other Sherpas come in and basically say that they were tent mates with this guy, and they were worried that the hemorrhoids were contagious, which I thought was pretty funny. But a lot of people up at high altitude just mix a dehydration, and then like kind of not wanting to eat, and then the fact that you're eating different diet. A lot of folks are prone to hemorrhoids up there. And then I'll just skip through some of this stuff.
5480 up on the ice fall.
See if anybody has any
Base came
questions.
down there, Pomori. Big old avalanche up here last night. That there is penis. Wow, rock, but it's ice. That comes into the base of the ice. Why they call it that? Wow.
So this on the left is, you know, kind of the route through the ice fall. I like to describe it as like ice climb jungle gym. And then this here is just an example. I mean, you see avalanches like this every single day up there. Sometimes it's unnerving when you're kind of in the middle of the ice fall in bad weather, and you can just hear these things going on. So that's just another example of that.
Wow. That comes in
See how
Oh my gosh.
big this thing is. And, you know, I don't have scale, but I mean, this just from here to here is several thousand feet.
Whoa.
And it's just like so fast. It's a massive avalanche. But I mean, that thing is still, you know, a mile away from us kind of thing, and we're not at risk where we are. Dealt with basically Serac is kind of one of those structures in the ice fall where you have kind of like the cascading crevasse laden glacier, and the Serac is basically just a big block of ice. So one of those things, it didn't like collapse down, but it just like dropped like 10 feet and hurt these two guys that were on top of that. And then there actually the same year was one of those that fell into a ladder and basically shot the ladder into a guy's femur and exploded his femur, which was a pretty wild case just from the standpoint of like the helicopter extraction of that climber. So musculoskeletal pain, this is like, you know, the typical load for these porters up there. It was pretty wild. This, I just got to show this video because it's already. This wasn't even like an absurdly like busy atypical day or like an emergency rescue or anything. This was just normal traffic up.
Oh.
So just wild, the like, I don't know, the shenanigans that happen up there in lots of different capacities. So this was our dining tent 2 years ago at the end of the season. There's just got a massive snowstorm and totally collapsed the tent. This is, I don't know if y'all have ever seen a video of the Lukla airport, but it's at like, I think I've read 12 degrees. It always seems steeper than it is. But this is a plane taking off. So I love my job. This, I don't know if y'all heard about excuse me, not avalanche, the earthquake that just happened a handful of days ago in Western Nepal. So these are some organizations that, I don't know, I give money to every year. Try to help out the guys that like have given me a lot of fun and reward going over there. These are really good resources just in terms of like being interested in wilderness medicine. So the Wilderness Medical Society, I'd say that's sort of the more academic group that has a lot of CME, and they have a conference every year in the spring and the fall, or excuse me, like the winter and the summer rather. So the next winter conference is going to be March 10 to 13 in Whistler. And those things are, you know, normally a handful of days. They have some like pre-conferences. They teach at each of those conferences this WLS, so Wilderness Life Support for Medical Professionals, which is how I know Heather Fullerton. Taught one of those with her. And then the Wilderness Medical Society, that also is the group that basically has the Wilderness and Environmental Medicine Journal, which is just this wemjournal.org. So if you go to that or just like Google Clinical Practice Guideline Wilderness Medical Society, you get their different guidelines that are free, which they update regularly. And then the World Extreme Medicine is also a really cool conference that I've been to. They always have in Edinburgh, Scotland each year. So I went last year, really bummed I'm not going this year. And actually it takes place in a couple of days. But if y'all have like CME money or just some downtime, they live stream that. And actually like all these groups live stream their conferences, I think. But that's a cool one just because it's a really, really international group. And they do a lot of like humanitarian and sort of like rural medicine kind of stuff, separate from Wilderness Medical Society. I think is more like the traditional wilderness expedition, dive medicine kind of topics. And then this group, Wilderness and Travel Medicine, they also do a Big Sky conference every year in Montana. That's a CME thing. And then they do a Santa Fe conference in like May. So those are all like really good ways to get your feet wet, and also like phenomenal networking. I'd say that like I've been able to do a lot of things that I've done just because of going to some of these conferences and meeting people, and just like keep my foot on the gas, and kind of schedule open. International Commission Alpine Rescue. So that's the group that is kind of like an academic climbing group. And actually they just met a couple weeks ago for their big symposium in the Dolomites, and they also put out like avalanche kind of consensus statements. They recently put out a basically like an updated version of like how long should you perform CPR in the backcountry, kind of clinical practice guideline. So I've done this thing, Diploma in Mountain Medicine, which is University of New Mexico and University of Utah through the Wilderness Medical Society offer that in the US. I actually did mine in Nepal. They offer it like a dozen places around the world at whatever intervals. And they now have this other kind of like variant in terms of like in-depth study in the dive medicine world. That's kind of cool if you're into scuba diving and marine medicine, that kind of stuff. And then in terms of like trying to take some of these courses and or like teach some of these courses. So I actually taught and took these when I was in medical school and residency. But these are a couple of the companies that do these things. So Backcountry Medical Guides, that's a cool group that does it. And one of their sort of like variants is they do some like sailboat trips where they, teach these courses. And then MedTrex International, they do a lot of these wilderness first responder, wilderness life support courses, but they also do some like travel medicine, global health CME stuff as well. BOBO is sort of the CME arm of this wilderness and travel medicine group. And they have, trips all over the world every single month. And then Adventure Med is one of the sort of like credentialing bodies. It's like a clearinghouse for a lot of these courses. And then if you Google this, Wild Med Wednesdays, it's basically just Zoom talks the first Wednesday of every month on some wilderness medicine topic. And I think that's run out of Yale's wilderness medicine program. But those are all really good resources. So this, happy to have y'all like reach out to me for questions, resources, what have you. I love talking about wilderness medicine, expedition medicine, and like I don't know, I always have the thought that like clinically, like just my day job kind of thing, I didn't get where I was without having awesome mentors, and similar thing in the expedition world. And if I can help network and connect y'all with something y'all are passionate about, like by all means. One thing that I didn't really talk about is kind of research component. So I think one of the things that has also been like a mainstay of my sort of like clinical curiosity within, it's sort of evolved, but within high altitude medicine, is being connected early on with some people that are doing a lot of research, and something that I've continued to do. Like I did, not last year, but in 22, I did a interesting little pilot study to see if heart rate variability could predict climb readiness or predict acute mountain sickness. And then, presented that at a conference and had some really cool conversations that like connected me to more people and ... So that's kind of all I had to share. Curious if you guys have questions, conversation.
That was super interesting. Thank you for talking to us. Maybe the most interesting PowerPoint I've ever watched.
Well, yeah, I don't know. Like it's a fun, it's fun and fascinating, and like every single trip is definitely different than the last. From the cohort of people there to just like random stories, learning new bits of some language, new foods. It's just like all of these like cultural things, just like all dumped into like a finite little 6-week or 8-week experience. And again, just like I've sort of prioritized like my clinical medicine job hospital medicine so that I can have the flexibility to do this kind of stuff. And the assumption I match, the next year from July to July is going to be a little different, I think.
Hopefully they pick you at Utah or Denver or something with all your wilderness experience.
It's actually kind of interesting. That's like some of the like interview conversations of like, you have all this, wilderness medicine experience, it's like there's a lot of crossover, but it's always fascinating to me that people ask me, kind of like making sure I understand that it's sports medicine and not wilderness medicine that I'm applying for.
Yeah, you're like, yeah, I know. I want to learn this stuff. Well, cool. Good luck to that. And thank you so much for speaking.
Yeah,
it
totally.
was quite fascinating. You've had a very cool career of very interesting experiences.
Yeah. Well, yeah. I mean, for sure. Good luck to you as well. Reach out whenever.
Thanks. Okay.
If I can be of help and connect you with whomever.
Cool. Thanks.
Yeah.
Yeah, Kristen, really good. You obviously put a lot of time into this. I really appreciate it.
Yeah, no, for sure. It's fun to see your face. I don't know if y'all know this, but I saw Heather at a marathon up here this summer in Missoula.
Yeah. Well, a half marathon for me, but yeah, as I finish, I'm looking around and there's Christian. So yeah, that's cool.
Yeah, I think Andrew's still attending to his call, so I'll just thank you on his behalf. But thank you so much, Dr. Dean. I mean, it's not every day we get to talk to someone who's trekked up the Himalayas, but not only that, you're a physician who worked there, so it's really cool getting that insight. I knew that going up there puts a big strain on pretty much every body system, but I did not. Some of the things on some of your slides, I did not think that was like a thing you'd have to think about when you go up there. So that was a really neat presentation. And I wanted to ask you, have you ever been in a position where like when you're in a situation where you wish you wanted something but you didn't have it? Was there a situation where you had access to something, you're like so thankful that you had it?
Yeah. I think it's an awesome question. I think I don't know, as I think of my answer, I think that I'll say that I've been able to have like awesome conversations in terms of helping me prepare and stock and like bring appropriate meds and supplies and that kind of thing from the doc that did this before me with the same team. So, in that regard, I think that there were a lot of things that, it's trial and error doing this kind of thing, but I was able to like stand on the shoulders of that dude. And in saying that, I think it's one of those things that like, it's really important, even though you're at Camp 2, like bad radio contact, whatever, like understand that you have allies everywhere and anywhere. I mean, even something as simple as, like getting a Sherpa, like who you have like run through simple first aid, discussions with to help you do different things. And like those things, do play out over the season, because invariably you like have some encounter with like, I don't want to say like multiple casualty, but multiple people getting hurt or injured at the same time, or like, just the like flow of the mountain. There'll be sort of like an evening descent after summits of people coming back into Camp 2. So like in the evening into, even like midnight, 2 a.m., like it's a busy medical time after a summit push. But yeah, I don't know. Like I think I carry a lot of information on my phone that is like quick resource for me. And I think some of that is, like I'm hypoxic up there myself. Like, I don't know if I'm thinking clearly. So from that standpoint, again, like have the ability to reach out to people. And I've even done that. Like I unfortunately dealt with a cardiac arrest at Camp 2 this year, and, like did what I thought with what I had was medically appropriate, but kind of like while I was still having somebody do CPR, like try to get radio contact with one of the doctors down at base camp and just say like, hey, this is what's going on. Like, what am I missing? Like, what else can I think of? Just in that like, I think just try to get resources that like are somewhere somehow in your bubble. I have I don't know where it is. I think it's in my car. I have this like little device that's literally this big. It's made by a company called Cardia, and it's a little like 6-lead EKG device. And they make it, it can actually dumb down and just be a single lead. But it can actually create like a really good 6-lead tracing. So I've like diagnosed AFib up there, which was, pretty interesting. I probably had AFib up there too.
Kristen, do you use your point of care ultrasound much up there also?
Yeah, you know what? I do. So I have, let me just grab it.
And then does Quinn have a question? I see the little hand raised.
Yeah, I'll wait till after.
Okay.
Oh, sweet. Yeah, so there's like Butterfly and Clarius and GE and whatever other brands, but I have the like Chinese knockoff thing that's linear and curvilinear, and it just charges on the same little like magnet thing as my iPhone, and Bluetooth to my phone, which I take to camp too, or my iPad, which I have at base camp. And you can diagnose pulmonary edema or pneumonia, blood clots, muscle tears, a lot of different things with this. And honestly, it's like one of the reasons I want to do sports medicine is to like become much more well versed in like what this thing can do for me in the mountains. But it's been a really cool tool. I haven't diagnosed a pneumothorax up there with it, but like I've diagnosed broken ribs up there. I don't know, it's interesting. So I think like one of these things of kind of like, what diagnostically do you have with you? I take a stethoscope up with me on, higher on the mountain. And then, the mainstay of those like altitude meds, and then a bunch of different antibiotics. And, like I was saying, like try to understand what medical history people have beforehand. So yeah, I don't know if I answered your question at all.
No, you did.
Yeah, quick.
Yeah, so I was kind of a two-part question. One, I'm wondering if you have any input on for physicians who are wanting to do some remote medicine type of work, specifically like in like the mountaineering setting, do you notice doctors from specific specialties that are more well suited to it? How important is specialty choice in wanting to pursue opportunities to practice like this? And then kind of second part of that is, what strategies do you recommend in terms of trying to get your foot in the door in this space, especially like during like the hectic schedule of residency, and then also after you get out into practice, dealing with contracts and what your schedule looks like with hospitals or clinics?
Yeah. So I mean, a totally relevant thing. So I think that me doing family medicine residency, like I didn't know what I was going to do with my career, but I really like chose that because I felt like it wouldn't shut doors on me, or it would shut the fewest number of doors. And that's like really played out in my career. Like I've done some awesome, cool things. And then to sort of like more specifically answer your question, I think like the stereotypical and just seeing what the wilderness medicine fellowships used to be off of was only emergency medicine. When I was a third-year resident, I actually spammed all of those programs. And I think this is like some answer to your second question of just like, be passionate about something, put your foot on the gas, and like don't let up. But when I was a third-year resident, I emailed all of the program directors of the wilderness medicine fellowships, which at that time were all off of emergency medicine. And I was like, hey, I'm interested. Look at my, CV, ... I even think that, if you link me to your family program and like have me, because a lot of it's like a funding issue with fellowships, have me work in like some urgent care that's tied to your hospital, that kind of thing, you know, I think it would work out and like I'd be a tremendous asset, And I actually had 3 programs interview me. I didn't get a spot, and then I ended up getting a job in Jackson Hole, and I was like, game on. And I think that that's like some of that other discussion of just like in Jackson, I surrounded myself, I think a little bit by people that are there. You know, like this guy, David Shem, who's one of the godfathers of family medicine, excuse me, travel medicine, you know, has written chapters in the CDC's Yellow Book. He lives there. You know, Jackson Hole is basically hosted Teton County Search and Rescue, which is one of the premier search and rescue groups in the world. Jenny Lake Climbing Rangers, like all these things are kind of like integral up there, and they all have medical directors, and those are like the ER docs that I worked with. So like having those folks is sort of like in my little wheelhouse. And then, you know, a lot of it also in terms of like meeting some of these people was like going to some of these conferences and just like putting your neck out there and like getting people's contacts, following up with them, asking them questions, asking them, you know, like how did they get into it, you know, ... And I think with me, it's a lot of just like persistence. I mean, I feel like literally I've combined my passion of like playing in the mountains with medicine for, you know, since I was 18. I did a wilderness first responder when I was in high school. I got an EMT in college. I was on an EMS. And then like with each of those things, I literally like when I would go on an expedition, sort of like ask the guiding service if they give me some discount because I had, you know, that level of medical certification. And then, you know, once I became a physician and, you know, things started steamrolling, you know, I think the doors opened a little bit more. But some of it also is just like checking some boxes of like the fellow of the Academy of Wilderness Medicine. It like in my mind, it's a little bit of a commercial product that the wilderness, sorry, let me plug my computer in real quick. The Wilderness Medical Society has as I think this like way to get a lot of people interested in this together, but also you know, it's like a phenomenal networking thing in and of itself, on top of, you know, checking boxes to learn and go to different lectures and that kind of stuff. Similarly, you know, those other groups that I had mentioned, you know, different CME courses, you know, I think it's just like getting out there and doing those things. And I think that one of the other things that's sort of like allowed me to like progress in terms of having things on my CV that catch somebody's eye is that I've taught courses, you know, for a long time. So, you know, when I was in medical school, I, you know, organized a wilderness first responder course, or what they call it. It was like a wilderness upgrade for medical professionals or something like that. It was like a weekend course. And, you know, just like organized it and made it happen. So, you know, I think doing that kind of stuff, and, you know, like I just happen to like love mountaineering, and like that has coincided with something that's sexy within wilderness medicine of like high altitude topics. But, you know, I have like a good buddy that like diving is his passion, and, you know, has done this dive medicine, diploma in dive medicine, and, you know, gotten some really cool jobs off of that. And, you know, kind of like working on boutique little cruise ships and traveling all over the world because of that. So I, you know, like not to be like short about it, but I think it's really just like, you know, meeting people, showing you're interested and passionate, and also like a little bit of persistent, have some persistence about it too. And, you know, the doors will start to open. I think like my sort of direct comparison is to this guy, Will Smith, who is one of the ER docs in Jackson, where I first worked after residency. And, you know, when I first worked up there, he's like the medical director of Teton County Search and Rescue, medical director of Grand Teton National Park. And like while I was there, he became the medical director of the national park system, like the whole thing. And I'm just sitting here like, how do I do what he's doing? And I think it's like really important to like understand that there's like time between, you know, him doing those things and having those titles, and like him getting interested and, you know, meeting people and that kind of thing. I think, I don't know, research, I think like sometimes has a negative connotation. But I think, trying to get involved, even with something as simple as like a case presentation, and like go present it at, some conference, whether like Wilderness Medical Society, their summer conferences are, I think, more geared towards learners. And they have like a poster presentation, so if there's like something that you could throw up on a poster and go present at their summer conference, I guarantee you the dean of your medical school will throw some money at you to go do that.
Yeah, definitely. No, that was really helpful. Thank you.
Cool. Anybody else have questions?
Awesome. Well, you guys got my email. Feel free to reach out whenever. Happy to connect you to whomever's in my wheelhouse that may help you. And definitely appreciate your questions, your time, your interest. Something I'm obviously passionate about.
Looks like
Yeah,
I
we
came
do,
a
Tom.
little bit too late.
Was that Andrew's voice? Yeah.
That's Andrew's back.
Yeah, I came back just to hear you say bye, but I'll definitely be watching the video once it uploads. So, but appreciate you coming out.
Yeah, for sure. And I mean, you got my contact info. Reach out whenever.
Awesome, will do.
Cool. All right, you guys have an awesome night.
You
Thanks,
too.
everyone. See y'all later.
See ya.
Bye,
you.
thanks.
Thank you.
Yeah. Adios. See you, Heather.